Hey everyone, welcome back to the channel. If you're new here, this is the place where we try to simplify dentistry for you. If you find value in today's video and want to continue learning, don't forget to subscribe and tap the bell icon so you never miss out on new content and lectures. Now, let's get started. In today's topic, we are discussing pulpal diseases. Before that, let's learn something about dental pulp. What is a dental pulp? A dental pulp is a connective tissue in a pulp chamber and root canals. It is composed of fibroblasts, vascular elements, stem cells, and myelinated and unmyelinated nerve fibers. As you can appreciate in the picture, the red outlined part is a dental pulp. A normal, disease-free dental pulp responds normally to pulp vitality tests. Histologically, it contains an intact layer of odontoblastic cells, a cell-rich zone, and a cell-free zone, with no evidence of inflammation or necrosis. When bacteria from carious lesions reach the pulp chamber, an inflammatory process starts in the pulp, corresponding to the location where the irritation reaches. This results in an inflamed pulp, resulting in pulpitis or even necrosis. Irritation of dental pulp may start from histamine, bradykinases, arachidonic acid metabolites from phospholipase A2, PMN lysosomal granule products, protease inhibitors, neuropeptides, and substance P. Moving on towards the classification of pulp diseases. We will be discussing each type in detail, starting with reversible pulpitis, which means the inflammation of pulp that is not severe. Removing the irritant or stimuli results in immediate relief. How does it occur? The main causes are incipient caries, cervical erosion, occlusal attrition as in bruxism, and enamel fractures, which result in exposure of dentinal tubules. Patients with reversible pulpitis usually have no symptoms, but the application of external stimuli such as heat and cold results in an increased intensity of pain. Histologically, reversible pulpitis typically shows mild vascular dilation, mild edema, but no necrosis. Cold and hot stimuli produce different pain responses in reversible pulpitis. When a heat test is applied to a tooth with reversible pulpitis, it shows a delayed initial response, with the intensity of pain increasing as the temperature rises. But there is an immediate response to the cold test, and the intensity tends to decrease if the cold stimulus is maintained. Radiographic examination reveals no periapical changes. It does not respond to the periapical testing. Removal of irritants and sealing and insulating the exposed dentin or vital pulp results in diminished symptoms. It can be done by restoring the carious lesion with a suitable restorative material and desensitizing the hypersensitive dentin. When reversible pulpitis is left untreated, it turns into irreversible pulpitis. It is the presence of severe inflammation in the pulpal tissue, resulting from the progression of reversible pulpitis. It does not resolve even if the cause or stimulus is removed. It results from severe pulpal damage from excessive dentin removal during a restorative procedure, trauma to the tooth, as in the cases of teeth grinding, and sometimes occurs after the orthodontic tooth movement due to impairment of pulpal blood flow. Histologically, some areas show the presence of severe inflammation, partial necrosis in the pulp, microbial invasion, intense inflammatory responses, and microabscesses. It can be symptomatic or asymptomatic. Patients may complain of pain being intermittent or continuous in nature, even when no external stimuli are applied. The pain can be localized or diffuse, and may be dull or sharp in nature, lasting from minutes to hours. When a heat test is applied to the tooth with irreversible pulpitis, there will be an immediate response. However, when a cold test is applied, the response is prolonged and does not disappear. Occasionally, application of cold in patients with painful irreversible pulpitis causes vasoconstriction, a drop in pulpal pressure, and subsequent pain relief. This condition is referred to as hot tooth. The radiographic examination shows no periapical changes. If the inflammation is confined and has not extended periapically, teeth will respond within normal limits to palpation and percussion. Extension of inflammation to the periodontal ligament causes percussion sensitivity and better localization of pain. Treatment includes root canal treatment or the extraction of that tooth, depending upon the extent of caries. The next condition is hyperplastic pulpitis, which is a form of irreversible pulpitis, resulting from the growth of chronically inflamed young pulp into occlusal surfaces. Why does this happen in a young permanent tooth? The presence of ample vascularity of young pulp, adequate exposure for drainage, and tissue proliferation is associated with the formation of hyperplastic pulpitis. Histologically, there is an inflamed surface epithelium and underlying connective tissue. The cells of the oral epithelium are implanted and grow over the exposed surface to form an epithelial covering. It is usually asymptomatic and appears as a reddish cauliflower-like outgrowth of connective tissue into caries that has resulted in a large occlusal exposure. It is occasionally associated with clinical signs of irreversible pulpitis, with spontaneous or lingering pain to cold and hot stimuli. It shows no radiographic changes in the periapical region and a normal response to periapical testing. Treatment depends on the extent and severity of caries and includes pulpotomy, root canal treatment, or extraction. Irreversible pulpitis, when left untreated, results in pulp necrosis. Pulp necrosis is the complete or partial death of pulp tissue. The pulp is encased in rigid walls, it has no collateral blood circulation, and its venules and lymphatics collapse under increased tissue pressure. Therefore, irreversible pulpitis leads to liquefaction necrosis. In addition to liquefaction necrosis, ischemic necrosis of pulp occurs as a result of traumatic injury that causes disruption of the blood supply. If an exudate produced during reversible pulpitis is absorbed or drained through caries or through a pulp exposure into the oral cavity, necrosis is delayed. The radicular pulp may remain vital for long periods. In contrast, closure or sealing of an inflamed pulp induces rapid and total pulpal necrosis and pararadicular pathosis. Histologically, there will be loss of cellular detail, architecture, and vitality of pulp. In coagulative necrosis, there will be ghost cells, eosinophilic tissue, and a little infection due to less bacterial involvement. The cells appear ghost-like because the outlines remain, but nuclei are lost. In liquefactive necrosis, there will be pus, neutrophils, bacterial colonies, and tissue liquefaction. The pulp tissue will be destroyed, replaced by amorphous debris and inflammatory infiltrate, with complete loss of odontoblastic layer. There will be thrombosis and destruction of blood vessels. There will be always a risk of spread of infection to periapical tissues. It is usually asymptomatic, because the nerve endings supplying the pulp are no longer present. But clinically, there are instances when patient can feel endodontic instruments that are exploring the necrotic pulp space. It may be due to remaining pulpal nerve fibers or fluid pressures that stimulate apical nociceptors. It shows no response to pulp vitality tests. The pain provoked with the application of heat is not due to an increase in interpulpal pressure. This pressure registers 0 after the heat application to teeth with necrotic pulps. Heat to teeth with liquefaction necrosis causes thermal expansion of gas present in the root canal, which provokes pain. In fact, cold, heat, or electrical stimuli applied to teeth with necrotic pulps usually produce no response, but show pain on percussion and palpation, indicating periradicular involvement. The radiographic examination shows normal or periodontal ligament widening. Treatment depends on the extent and severity of caries and damage, and options include root canal treatment or extraction. Next is, if the tooth is treated previously with placement of some sort of obturation material and there are some factors that are causing pain, what will you do with that tooth? The management depends on various factors, including the restoration and accessibility to remove prior obturation, material in an orthograde fashion, the feasibility of surgical access, and patient preference. Treatment options include non-surgical or surgical root canal or extraction. There are many cases when pulp therapy is initiated, but due to some factors, it is not completed. In such cases, pulpotomy or pulpectomy may be done, and some intercanal medicaments may be in place. There may be evidence that endodontic access assessment should be made as to the extent of prior treatment and any anatomic alterations or procedural errors that might require additional treatment. Treatment options include extraction or root canal treatment. The next is pulp calcification, which occurs in the form of pulp stones or diffuse calcifications. It occurs as a response to trauma, caries, periodontal disease, or other irritants. Thrombi in blood vessels and collagen sheaths around vessel walls are possible niduses for these calcifications. One of its forms is calcific metamorphosis, which results from extensive formation of hard tissue on dentin walls. It occurs often in response to irritation or death and replacement of odontoblasts. As irritation increases, the amount of calcification may also increase, leading to partial or complete radiographic but not histologic obliteration of the pulp chamber and root canals. As you can appreciate in the picture, the more yellowish color of the incisor shows calcification. Histologically, it shows 3 patterns. In case of diffuse calcification, there are scattered fine calcific deposits throughout the pulp. In case of pulp stones, there are localized calcified masses within the pulp. And in complete obliteration, the canals are fully replaced by hard tissue, in which no pulp is left. The main characteristic is the yellowish discoloration of the crown. It is usually asymptomatic and may complicate the endodontic procedure if started. The pain threshold to thermal and electrical stimuli usually increases, or the teeth are unresponsive. It shows a normal response to periapical testing. The radiographic examination shows a reduction in coronal pulp space followed by a gradual narrowing of the root canals. Treatment is aesthetic treatment only, to mask the discoloration. The last is internal resorption. The pulp is transformed into vascularized inflammatory tissue with dentinoclastic activity. This resorbs the dentinal walls, advancing from the center to the periphery. These images are showing a characteristic pink hue in the incisor, which is the main feature of internal resorption. Histologically, there is resorption lacunae in the dentin. Dentin tubules appear broken or discontinuous at resorbed areas. Odontoclasts or multinucleated giant cells occupy the resorption bays, also known as Hauschup's lacunae. The pulp shows chronic inflammatory infiltrate and sometimes the granulation tissue grows into the resorptive defect. In some cases, areas of resorbed dentin are replaced by irregular calcified tissue. This represents a repair attempt by pulp. It is usually asymptomatic, and shows a pink spot in the crown. It shows a normal response to both pulp and periapical testings. Radiographs reveal a radiolucency with irregular enlargement of the root canal compartment. These lesions tend to be very progressive and eventually perforate to the lateral periodontium. When this occurs, pulpal necrosis ensues, creating major problems in treatment options. Teeth with perforated resorption are difficult to treat non-surgically. Treatment includes the immediate removal of inflamed tissue by doing root canal treatment. Surgical treatment is the only option to treat teeth with perforated resorption. That's it for today. Thank you for watching. If you find this video helpful, and you gain even a little bit of knowledge, give this video a thumbs up and share it with your friends and study buddies. Don't forget to subscribe for more dental videos and lectures. Your support matters to us. See you in next video.